Welcome everyone, and thank you for joining us, the first Retina Case Club in 2026. We are focusing today on the management of difficult cases in the retina clinic. I'm Sandrine Zweifel, Vice Chair from the University Hospital of Zurich. With me today as co-chair is Professor Giuseppe Querques from the University of Modena. We have 5 exciting cases prepared for you today, and I'm looking forward to hear each of the speakers. But before we begin, just a quick note. You can submit questions via the chat Q&A function, and we will address them either at the end of the presentation or during the discussion time after the 5 speakers. Now I would like to give the word to Giuseppe, who will introduce the first speaker.
Thank you, Sandrine, and congratulations to Euretina for such important initiative. It's really helpful for all of us discussing difficult cases. And the first speaker will be from my department, actually, Martina Fantuzzi. Please.
Good evening to everyone, and thanks to the committee for the kind invitation. This evening, I am going to present a case of a 37 years old man. Sorry, camera. Okay, 37 years old male, Caucasian, that presented to our emergency department with a decreased visual acuity in the right eye. During examination, the patient has a best corrected visual acuity of 20 out of 100. Anterior segment and IOP were normal, and at the fundus, the patient presented vascular abnormalities, macular edema, and small hemorrhages in the superior and temporal quadrants. The left eye was within normal limits. The OCT confirmed the presence of cystoid macular edema in the right eye. Our initial working diagnosis was multiple branch retinal vein occlusion. Therefore, we prescribed a complete systemic workup comprehensive of complete blood count, lipid profile, homocysteine, monitoring of systemic blood pressure, coagulation profile, and carotid and aortic trunk ultrasound, as well as cardiology consultation. The workup revealed hypercholesterolemia, hyperhomocysteinemia, and a heterozygous mutation of MTHFR gene and a variant of PAI1 gene. During cardiology consultation, it was decided to start statins, folic acid, vitamin B12, and also low-dose aspirin. We also planned a fluorescein angiography. In the posterior pole of the right eye, we can see microaneurysm and in late phase macular leakage, suggestive of macular edema. Also, arterial aneurysm were present. Arterial aneurysm were also present in the mid and in the periphery of the retina, and a capillaritis and areas of capillary non-perfusion were present both in the superior and temporal and inferior retina, as you can see in the images. The left eye was completely normal. The FA led to the exclusion of multiple branch retinal vein occlusion. So we had to think of another diagnosis. So at the examination and at imaging, there were arterial aneurysm, capillaritis, and peripheral capillary non-perfusion and macular exudation. All these findings were compatible with unilateral IRVAN syndrome. IRVAN stands for Idiopathic Retinal Vasculitis, Aneurysm, and Neuroretinitis. We decided to treat our patient with focal argon laser photocoagulation and a slow-release dexamethasone implant. 4 days after injection, the patient came back to our clinic with a blurred vision in the right eye. The BCVA was 2 out of 20, and the serial test was positive at the scleral tunnel, with an IOP of 5 millimeters of mercury. The OCT showed choroidal folds suggestive of hypotony. We decided to put a comprehensive bandage, and the day after, the patient came back and the Seidel test was negative and the IOP normalized to 15 millimeters of mercury. At 3 months follow-up, during examination, the BCVA was 20 out of 20. At the anterior segment and IOP is still normal, and the fundus presented macular aneurysm, multiple arterial aneurysms, and vasculitis. And the OCT showed no macular edema. At 5 months follow-up, the right eye had a best corrected visual acuity of 10 out of 20, anterior segment and IOP normal, and fundus presented macular aneurysm, multiple arterial aneurysm, and vasculitis. But at the OCT, there was a relapse of macular edema. These are fundus photography of both eyes. In particular, in the right eye, we can see multiple arterial aneurysm and hemorrhages in the temporal and superior sector, and also vascular sheeting is present, suggestive of vasculitis. We repeated the fluorescein angiography, where we can see in the late phase the macular leakage, suggestive of macular edema, multiple arterial aneurysm, especially in the superior sector. There are many aneurysms. There's vascular leakage and areas of non-perfusion. This is a recent exam, so the patient still has to come to the visit, and we still have to decide what's next, so the next treatment. And it will be interesting to hear from the panel also what they will suggest as treatment for this patient. To conclude, although IRVAN is commonly bilateral, few unilateral cases have been reported in literature, and in many cases, signs of neuroretinitis are absent, and a new term has been proposed, IRVAN, idiopathic retinal vasculitis, aneurysm, and retinal exudate. Dexamethasone implant has proven to be effective in this patient, at least at the beginning. Samuel and colleagues suggested 5 stages of the disease. In particular, stage 1 are present macroaneurysm, arterial bifurcation, exudation, neuroretinitis, and arterial vasculitis. At stage 2, angiographic evidence of capillary non-perfusion, and at stage 3, posterior segment neovascularization and or vitreous hemorrhage. Stage 4, anterior segment neovascularization. Stage 5, neovascular glaucoma. According to literature, the management should be at stage 1. You could either observe or treat with the systemic steroids or DMARD. At stage 2, laser photocoagulation should be combined with systemic or intravitreal steroids, or also anti-VEGF therapy showed efficacy. And PRP, so pan-retinal photocoagulation, should be deferred until ischemia involves more than 2 retinal quadrants. From stage 3, PRP is mandatory and could be associated with more aggressive treatment, such as vitrectomy. Thank you for your attention.
Thank you, Martina. I think Sandrine, we should make questions, comments after at the end of each presentation, or we prefer to make it all at the end of all presentation?
I would actually address questions from the Q&A after each presentation.
Yeah.
I think there is one question: would sector photoretinal coagulation not be beneficial in the area of ischemia? And I think this is something which is controversially discussed, that even an early laser treatment of ischemic areas in IRVAN can be beneficial. So in the beginning, the first description of the cases, people saw that actually the prognosis is very good and the course is actually good. and in the later publication, we have learned that there can be quite an aggressive outcome or an aggressive course of the disease. And that's why even in the absence of retinal neovascularization, early laser treatment is recommended. Would you agree, Giuseppe?
I definitely agree. I mean, this is I believe this is a very beautiful case because it's highlighting different aspects of disease. Well, first, this is a unilateral that is quite unusual, and so may lead to misdiagnosis. Then it's not that aggressive. I mean, at least if we during follow-up, that was not that progressing that much, and in terms of ischemia, but still presenting with edema. And so, as you suggested, a focal treatment or preventing extensive and progressive disease may be beneficial. So targeting with the laser may help. And the third aspect is the way edema was managed. That again is not that frequent in current literature. I mean, it's another point that could be discussed, whether or not steroids may be better than other approaches, including anti-VEGF. So there are different aspects in this case that highlight how peculiar is the disease and how this could be presenting in everyday clinical practice. I've seen another question suggesting how can we differentiating this from Cozzi disease. Well, that's another point. I mean, this case was not exactly Cozzi because of absence of extensive exudation, hard exudates, and also because of this bulb-like dilation over retinal arteries. So this helped in differential diagnosis. But again, I mean, this is one of the differential diagnosis. In the end, management is similar. I mean, we should start with laser relatively soon and eventually managing edema with best approach that could be steroids or anti-VEGF.
And maybe it would be nice because we actually will address the differential diagnosis of Cozzi disease in the second presentation, and maybe we can actually address this question even better when we heard the next presentation, also from Italy. And I would like to introduce Laura Ponti. She is also from the Department of Ophthalmology at the University of Modena, and she will present a case with adult onset Cozzi disease.
Thank you. Good evening to everybody. I would like to thank the scientific committee for the opportunity to present this case this evening to the panel and to the audience. And I would like to present this case because I think it challenges us to think more broadly about diagnosis and treatment in retinal vascular diseases in adults. So I have no financial disclosures. This is an otherwise healthy 37-year-old male patient who presented with unilateral visual symptoms and a slowly progressive course. He had an unremarkable medical history, and at presentation, the best corrected visual acuity was 20/32 in the affected eye. Slit lamp examination and intraocular pressure were unremarkable. And on fundus examination, the most striking feature was the macular involvement with vascular changes and central exudation. So this is the first fluorescein angiography we have available. And as we can see, there are microvascular dilations with central exudation. These angiographic abnormalities were described at the time to be only present in the macular area. Based on the patient's adult age and the presence of central vascular changes and exudation, the initial working diagnosis was sequelae of branch retinal vein occlusion. If we look at the same fluorescein angiography retrospectively and more carefully, we can see that there are other elements present. For example, subtle telangiectatic vessels and aneurysmal dilation can be observed not only in the macular area, but also expanding beyond the central retina. Although there was no lipidic exudation at the time, I think these additional elements can already raise a suspicion for an alternative diagnosis. So, based on the initial diagnosis of retinal branch vein occlusion, the patient was started on anti-VEGF treatment, initially with aflibercept loading dose. There was an initial partial response to the treatment, but the effect was not sustained over time. So treatment was switched first to a dexamethasone implant and later to multiple injection of different anti-VEGF treatments. And they were administered according to the evolving clinical picture. Other than anti-VEGF therapy, the patient was also treated with macular subthreshold laser and later with laser photocoagulation of areas that were described as peripheral ischemic areas. As we can see during follow-up, the main feature was the damage to the central retina. Lipidic exudation was increasing, macular edema was becoming chronic, and structural changes were becoming more evident. Also, the fluorescein angiography showed us the presence of telangiectatic areas in the peripheral areas, but there were never any peripheral exudation. So the structural changes mainly remained confined to the central retina. So this brings us to the last visit of the patient in our retinal center. And as we can see, the lipid exudation is evident and reflects a long-standing vascular leakage. Despite the advanced stage of the disease, peripheral involvement is more limited compared to the macular damage. Also, the best-corrected visual acuity has remarkably been reduced to 20/630. And as we can see on the OCT, macular damage reflects a long-standing vascular leakage. Multimodal imaging, including fundus photography, OCT, and also the review of all the angiography pictures allowed us to make a diagnosis of adult onset Cozzi disease. Unlike the pediatric disease, which usually has a more extensive retinal involvement and also has more serious complications like neovascular glaucoma and exudative retinal detachment, the adult disease has a later onset and a slow indolent progression. Adult disease also usually has a localized retinal involvement, and also the vascular changes can be more subtle. So adult disease for these elements can easily be misdiagnosed as a more common retinal vascular disease. This brings us to the current picture, and as we can see, lipid exudation and macular changes persist despite multiple and prior interventions. If we compare the initial presentation to the current imaging, the progression is striking, and this highlights the challenge of this case. In particular, the macular involvement dominates the clinical picture and drives the prognosis. So now I would like to ask the panel one question. How would you manage patients with advanced adult onset Cozzi disease with mainly macular involvement and a limited peripheral involvement? Thank you.
Thank you, Laura. That's another beautiful case. I mean, I know these cases because we were discussing a lot with both of you and internally in our department about these cases. It's a very difficult case to manage. As you highlighted, this patient was treated with all different treatments available, but still increasing in terms of edema and the hard exudates. And the points that we cannot even manage this patient with peripheral laser or targeted laser in the periphery, because one and probably the most peculiar aspect of this case is the almost normal. You highlighted the tiny changes in the periphery that are typical for Cozzi-like diseases, but again, they are definitely too mild to be approached with laser, with focal laser, with sectorial laser, and unfortunately, it seems that this patient is not responding in terms of exudation and all the deposition of hard exudates to the different intravitreal approaches. So I don't have an answer. I mean, I think that we already attempted all the potential treatment for macular exudation, and leave the work to Sandrine and eventually to the others.
Yeah, unfortunately, I don't have the solution here. We are also facing this challenge of having like an effective treatment for this patient. As you nicely shown at the end, you have also not anymore a nice retinal architecture, so that the prognosis and outcome is anyway limited. And we also try like all these different agents we have available, but at the end, actually, very often, nothing really works. So with that, I would say we have to move forward. Thank you again for these interesting, challenging cases. And I think we also discussed a little bit that actually these diagnoses, of course, are differential diagnoses for each other. Now we are moving forward. The next presenter will be Dr. Katrin Fasler. She is a senior consultant at the University Hospital of Zurich, and she will present another tough case.
So thank you very much for the introduction, and thank you very much for the two really interesting cases from Italy. I would like to continue with somewhat of a tough case, more in diagnostics than in management. And the presentation title alludes to something that doesn't belong and unfortunately isn't as cute as this kitten. So I would like to share with you the findings of a 32-year-old female. She presented at the eye casualty on Friday night with temporal visual field defect quite centrally that she's noticed since about a week. She's also experienced some dizziness. Otherwise, she has ocular migraine with a visual aura, atopic dermatitis. She's slightly myopic, otherwise fit and healthy. We could see the slightly decreased visual acuity, and otherwise the anterior segments were unremarkable. She also did not have any pupillary abnormalities on testing. And we did have a visual field test right in the beginning, which showed really nicely what she told us, that, oh, sorry about that, I was too quick, a visual field defect only in her right eye to the temporal side. On fundoscopy, sorry about the typo, on the right, this should be OS for the left eye. On fundoscopy, we could see change inferior nasally from the fovea, which actually corresponds quite well to the visual field defect that we had seen. And when we laid an OCT over the area that was not normal, we could see quite nicely what this discoloration on fundoscopy was. It was subretinal hyperreflective material and the tiny amount of subretinal fluid. I have also brought you the videos of the OCT, so you can appreciate the whole macular area. The left eye, completely normal. And this then provoked us to do an OCTA, because we suspected in this area to find vessels. And on OCTA, we could confirm this. It very nicely showed what we would probably all call CNV. So we halfway solved the case. We would argue that her quite central visual field defect is associated to this choroidal neovascular membrane that we have seen, but we still had to find out where this neovascular membrane came from. Now, the differential for a CNV, of course, is very different in young patients than in older ones. She wasn't in the right age range to simply be called AMD. So I've shown you the different differentials that we had thought of. She does have quite a thick choroid, even though I might have exaggerated the choroidal thickness a tiny bit on those measurements. So could it simply be a secondary CNV due to CSR? Or maybe it could be something else. And I think you agree with me that I have withheld some helpful information. Of course, we didn't only do a fundoscopy on this central part, but we also looked a bit further out, and things look a bit different now with the pretty large area of abnormality around the optic disc, which some areas look quite atrophic, and there's quite big blood vessels around there, some pigmentary changes. So we have to look for a diagnosis for this now. Might this have something to do with the CNV? So I have more imaging for you. This is a wide field OCT over almost the whole area of the pathology. And here I have some more details for you. So the OCT scan underneath the optic disc, you can probably also see somewhat of a change in choroidal transmission. Could that be a border of a calcification, maybe? I also brought you a OCT slab further down where there's that large blood vessel, which is also visible on OCTA. So there seems to be some intralesional vasculature visible. And I also have some separate OCT slides where you can appreciate some other features that I've highlighted. There seems to be the red star, some more dense, maybe cortical part. The blue star is some more spongy, not so dense parts. The yellow arrow points to a more or less horizontal line. And in the pink and green arrows, you see the sclerochoroidal junction as well as the rest of what's still there from the choroid, which is pushed to the outside by this lesion. We also did sonography. I said before, we suspected some border of some calcifications, and then in sonography is always a good idea. And we could see a typical hyperreflectivity of something that has calcium in it. The lower right image almost looks like an optic nerve, which it's not. It's just a shadow of the calcification. And and here we also did wide field fluorescent angiography and autofluorescence, where you can see somewhat early hyperfluorescence with light staining on angiography, some leakage in the area of the CNV. And on ICG, I find quite impressive the broad hypocyanescence with the interlesional vessels that are still visible in the choroid. So with all this quite extensive imaging, we thought we could now put a name onto this entity. It wasn't anything from the first 4 broad areas, but we decided it was a benign tumor. I guess most of you have come to the same conclusion. Her secondary CNV is due to a really large choroidal osteoma. She is actually a very typical patient to present with choroidal osteoma. It's typically diagnosed with teenage or younger females. It's typically unilateral, otherwise healthy eyes, not associated with any other systemic issues. And we have diagnosed her with the most common complication, that is a secondary CNV that may affect 30 to 50% of all choroidal osteoma patients. So I think I have shown you a case, something that definitely doesn't belong in the eye, which is mature bone tissue. As for the patient, after we talked with her about the diagnosis, we told her that we would need to do a treatment for her secondary CNV, which was, as usual, anti-VEGF injections. And we have seen her just about 2 weeks ago, and she has shown a pretty cool response already to the first injection. So we're quite happy with that. For the choroidal osteoma, we are on a watch and wait approach. We do not have any earlier images. It's her first appointment at an ophthalmologist that she's presented with us, so we do not know anything about progression, and so cannot actually say anything about possible therapies. Therapies that are done for choroidal osteoma include laser therapy or photodynamic therapy, mostly to halt or decrease growth of the lesion, especially when it's getting closer to areas where the vision would be affected. So thank you very much. Open for questions.
Thank you very much, Katrin, for showing us and sharing this amazing case, and also like I think it's amazing what kind of imaging modalities we have available to actually look at such a lesion in great detail. There is one question from the audience, and you can actually address it. It's about the differential diagnosis. So you showed us very nicely the calcification within the choroidal osteoma. The question is, what about the differential diagnosis of serpiginous, metastasis, choroidal lymphoma? Maybe you can also say a few words how, for example, a lymphoma or a metastasis look on OCT.
Yes, so I think the multimodal imaging approach shows pretty much very typical features of a choroidal osteoma with the typical aspects of cortical and spongy bone. Of course, we have done all this imaging, especially also the fluorescent and ICG angiography, to exclude other possible more threatening diagnostics. Yes, for example, metastases, they typically do not have any calcifications. They do not have any bone spicules or lamellar lines within them. They also are typically a lot smaller, more roundish in the choroid. So those are all features that together then led us to exclude all the other diagnoses and label this osteoma.
Yeah, I can just comment on the importance of widening the investigation, so widening the field of investigation of you. And this is, I guess, definitely pertinent to the way we are managing patients in a busy clinic. So we are more and more focusing on the central view, central OCT, central fundus autofluorescence, central picture, because of lack of time. So we really need to speed up the management of patients and also, imaging related to different diseases that we are managing. And as you nicely highlighted, if we were just focusing on the central field of view, 30 degrees and so on, we have been missing important information that then were leading to the right diagnosis, including ultrasonography and targeted OCT, for example. And we were more focusing on the pachychoroid that was associated with the CNV. So that's a nice, very nice case, not only for the intriguing diagnosis, but also for motivating all of us to spend few seconds, minutes more for all our patients and looking at and widening the field of view. So looking at the mid-periphery, at least the mid-periphery. This will help definitely managing properly cases. So I think we can move to the next case from Mariano Cozzi, that will give a real-world perspective on GA, geographic atrophy. I think you are muted, or we cannot hear you. I think you're not muted, but we cannot hear you.
You hear me now?
Yeah.
Okay,
that's good.
Thank you very much. Thank you for the kind introduction. And our case started in 2008, where this 65-year-old architect was referred to medical retina service at the University Hospital of Zurich for suspected age-related macular degeneration. Visual acuity was 910 on the right eye, 810 on the left eye. IOP was within normal limits, and anterior segment and family history were completely unremarkable. Here are the color fundus photography, and from these pictures we can clearly see presence of large drusen at the level of the posterior corner, expanded even behind retinal arcades. And these pictures perfectly fit with the classification of AMD that was published actually in 2013, where large drusen above 125 microns with presence of pigmentary abnormality fit into the intermediate AMD. OCT scans confirm presence of large and soft drusen at the posterior pole, also involving the fovea with some hyper-reflective foci. We were in 2008. In the last 10, 15 years, we have learned a lot using spectral domain OCT with several different OCT features that are now connected to the progression of the disease from intermediate till late phases. So at the end, the diagnosis was clearly intermediate AMD. The patient was completely asymptomatic. We preserved central vision. So they gave to her an observed grid for self-monitoring, and then the patient was, of course, asked to come earlier in case of visual changes occurs. And here we come with the entire follow-up of this patient till 2021. The patient came yearly after 2011. As you see from fundus autofluorescence, Geographic start to develop geographic atrophy at the beginning, not involving the fovea, and that's starting to partially involve also the fovea. What is interesting from these OCT scans are the presence of drusen. If you see the drusen at the level of the fovea and also in the perifoveal area, we see a slowly decrease of the drusen load, and then after 2018 we start to see some OCT typical signs of geographic atrophy. This is very similar. This kind of characteristic of progression is very similar on the left eye. In fact, we see the presence of these drusenoid deposits at the level of the fovea that suddenly start to decrease, and we can also see that the RPE and the outer nuclear layers, photoreceptor layers, are well preserved even after the disappearing of the drusen material. So we started to perform fundus autofluorescence and to follow this patient with fundus autofluorescence. And here we see the enlargement of RPE atrophy in both eyes, and we see this enlargement comes toward the fovea and also eccentrically, leaving just a small island of preserved macular photoreceptors in both eyes. And as we said also before, it's important to go wider. This is green fundus autofluorescence from Optos, and we see that surrounding the area of atrophy, we have this aspect of hypotofluorescence that also involve part of the area nasally to the optic nerve. So in 2024, the VA was very poor on the right eye, or at least was 1.6 out of 10 on the right eye, or still preserved on the left eye with a VA of 8 out of 10. Now, if we go back a few months before that, the pegcetacoplan was firstly approved by FDA as the first treatment of geographic atrophy secondary AMD. As we know, the pegcetacoplan is a complement C3 inhibitor administered by intravitreal injection. In phase 3 clinical studies, the Hawk and the Harrier, Derby, they investigated two different dosing regimens, monthly or every other month. And here we have the results of month 36, showing that for geographic atrophy not involving the fovea, the reduction of progression of the GA area was up to 32% for the monthly regimen, nearly 20 more than 20, nearly 28% for the bi-monthly regimen. So on that day, on that visit, and here we come with the core of the presentation, there was the consulting with the patient, and we started to support and discuss with the patient the possibility to treat geographic atrophy. In fact, what is important here is the patient selection, and in this case, we had a bilateral geographic atrophy with documented progression, the absence of advanced central vision loss, and was very important is that patient was super motivated and was able also to adhere to the long-term treatment. On the other hand, we also discuss with the patient the treatment expectation, and this is something that is very important. In fact, the goal here is not to halt, but at least to slow the progression rate of GA expansion. We can't expect any improvement in terms of visual acuity. And what is also important is that the patient understands that the benefit of the treatment doesn't come immediately, but is like starting a long journey. Of course, treatment burden and safety were also discussed, and at the end we decided to start the treatment with pegcetacoplan every other month. And when you start treatment, when you start to consider treatment geographic atrophy, you need firstly how to understand how to define and measure the GA area. We have different approaches. One is based on fundus autofluorescence, which is a semi-automatic GA quantification using the region finder. The other one that comes later is the possibility to use an AI-based algorithm using a software that is able to identify RPE depletion and give us, based on the OCT, the area of the atrophy. At the same time, with these new softwares and new approaches based on OCT, we could also evaluate the ellipsoid zone area loss. And as we can see from this slide, the EZ loss is larger than RPE as it comes first, and then we have RPE. These two methods are well comparable, and so we can now start to follow this patient before and after the treatment. We uploaded several OCT scans. As you see here from the plot, from the RPE depletion enlargement from this plot, there are some notches, like there are some assessment where the area was smaller than before, and this is of course is due not to the disease itself, but probably the quality of the OCT. Since we are now using an OCT-based approach, quality of disease is absolutely important. So we have shown the one of the few cases that were treated at the University Hospital of Zurich for geographic atrophy. The most important aspect that we have to consider is the patient selection, and the benefit of the treatment is long-term, and what is also important to consider, this is an anatomical benefit. And to conclude, we don't have enough real-world data, we don't have enough real-world experience, and this might help in the future to firstly have a dedicated treatment in Europe for these patients, and help to gain more information about this particular disease and treatment outcomes. Thank you.
Thank you very thank you very much, Mariano, for this excellent presentation. As you just highlighted, there are still some unmet needs in retina. There are diseases where we have limited treatment options available, and so far these anti-complement inhibition treatment is like one option for these kind of patients, although as you highlighted, we still don't know yet if what we see as a decrease in the growth rate of atrophy really translates also into a better functional outcome. We are still left just having like a structural outcome parameter where we see a treatment effect. However, We don't know if it really leads to a functional effect. But of course, this is the only treatment which we can actually provide to the patients up to now. We are in the last 10 minutes, so we move forward to our last speaker, a junior consultant from the Department of Ophthalmology of the University Hospital of Zurich, Maximilian Jacobi, and he will give you another challenging case. Max, we cannot hear you yet.
How about now?
Yes, perfect.
Okay, I have no slide control yet. I can't change the presentation. Okay, there we go. All right, thank you very much. Yes, I was going to say thank you very much, Sandrine, for the introduction, and thank you for the opportunity to present this case. The patient I'm presenting today is a 73-year-old Caucasian male who was initially referred to our clinic in 2021 due to an intraocular lymphoma. The patient reported increased vitreous floaters and opacities in the past year. There'd already been done a vitreous biopsy at an external clinic, which had revealed a B-cell non-Hodgkin lymphoma in the vitreous. Staging examinations showed signs of a subclinical cerebral lymphoma involvement. Subsequently, the patient was treated with an intravitreal therapy of rituximab, as well as a systemic chemotherapy. This worked very well, and the lymphoma lay dormant for several years. The patient was referred to us again in March of 2024, not because of the eyes, but because he'd suffered a significant recurrence of the cerebral lymphoma this time. Ophthalmological examination did, however, reveal in lymphoma infiltration of the retina on the left side, as can be seen on the OCT and fundus photography images here. The patient was once again treated with a local therapy of rituximab, intravitreal injections, as well as a systemic chemotherapy. As can be seen on the OCT here, this did lead to a significant decrease of the intraocular lymphoma. Unfortunately, the cerebral manifestation did not respond very well to chemotherapy. It was therefore decided by our colleagues in the hematology department to do a CAR T-cell therapy, which the patient received in October 2024. This caused a complete regression of the cerebral findings. However, as can be seen on the OCT images here from 4 weeks before and 4 weeks after the CAR T-cell therapy, the ocular findings showed a significant increase of pathology with diffuse swelling of the retina, epiretinal and intraretinal infiltrates. The optus fundus photography shows particularly normal findings, as can be seen here, prior to the CAR T-cell therapy. And then 4 weeks later, we have these white lesions, especially on the left side, but in the fundus autofluorescence, you can see that even the right side, which had previously been quiet clinically, now shows manifestations of the lymphoma. FA was also performed. The right side was pretty unremarkable, but the left side showed significant inflammation of the vessels. We had central leakage, and the ICG shows some hypofluorescent spots. Now, before I continue to tell you what happened next with the patient, I'd like to give a quick overview of what a CAR T-cell therapy is. Chimeric antigen receptor cell therapy is a second-line novel therapy that's been used for several years, particularly for B-cell malignancies and multiple myeloma. There are, however, a multitude of studies for all sorts of malignant tumors, and this is due to the fact that the idea behind the CAR T-cell therapy is frankly quite ingenious. The patient's own autologous T cells are extracted. They're genetically modified in vitro to develop receptors that can bind to tumor-specific antigens. Subsequently, the modified T cells are reinfused into the patient so that they can then specifically attack the tumor cells. Importantly, it is necessary to do an immunosuppression of the patient before you stop therapy. Otherwise, the body's immune system would attack the modified T cells. While this has been proven a very effective treatment especially for hematological tumors and malignancies, it is not without side effects. There can be a number of diffuse and sometimes very severe inflammatory reactions, which are called an immune cytokine release syndrome. They can, which can be very severe, causing shock and can even be fatal. Additionally, patients often experience a number of neurotoxicities and neuropathies associated with it, are called the ICANS. Ocular side effects have also been reported, and similar to the systemic side effects, they can be very heterogeneous, ranging from mild manifestations like conjunctivitis or anterior uveitis to severe pathologies like retinal vasculitis, retinal detachment, and optic neuropathy, which is linked to the ICANS, as I talked before. Additionally, to these inflammatory responses, there have been a number of reports of a rather, which I think explain what happened in this case, namely that if there is a case of an intraocular lymphoma and there is a CAR T-cell treatment, a systemic lymphoma will respond very well to this treatment, as with our patients. Cerebral manifestation disappeared almost completely. However, strangely, there can be a significant increase of lymphoma activity in the eye. The pathomechanism of this is not entirely understood. However, in the literature, it is thought that this is due to the immune privilege of the eye, and that the blood-retina barrier and the blood-aqueous barrier prevent the CAR T cells from entering ocular structures. And subsequently, due to the immune depletion we'd done before, the lymphoma cells in the eye can proliferate and expand basically unchecked, which can cause these significant exacerbations as seen in our patient. We treated the patient similarly to how we would have treated the intraocular lymphoma. He received repeated intravitreal injections with rituximab. Additionally, systemic steroids were used to tamper the inflammation. And finally, because the manifestation was so severe, an additional chemotherapy was performed by our colleagues in the hematology department. These are the final images we have from the patient. As you can see, there's still a significant number of retinal infiltrates that can be seen, especially on the left side. The right side remained rather quiet. The inflammation, however, especially the vitritis, did subside. And fortunately, the patient recovered his vision, which in the initial stages had decreased from 20/20 to 20/60. And in this visit, he had gotten back up to 20/20 actually. Unfortunately, some 6 months after the CAR T-cell therapy, the patient did suffer from a significant recurrence of the cerebral lymphoma, which eventually proved to be fatal. In summary, I'd like to present this case to show that while there are many new and very exciting treatment options for cancer these days, they often come with rather strange and unexpected side effects, including with the eyes. In this case specifically, I'd like to point out that particular care must be taken if there's a case of an intraocular lymphoma and the patient receives such a CAR T-cell therapy, to monitor the eyes very closely, because there is a possibility, however rare, of creating a significant increase of intraocular lymphoma activity, which can, if left unchecked, cause significant irreversible vision loss. Thank you very much.
Thank you very much. So, a great case, and I would say that's definitely typical in my patients. So not much to say, but I think there's an interesting question from the audience asking how can you differentiate an intraocular inflammation versus a reactivation of lymphoma in this case. So how can you make a differential diagnosis from the findings that you showed from inflammation
Yes.
versus reactivation?
It's certainly a very complicated thing to say in this case. The problem is obviously we have a patient who has confirmed vitreoretinal lymphoma, so we know that even with successful treatments, there's always risk of a relapse. In this case specifically, I think the answer is that it is not possible to be entirely sure. However, the side effects reported with CAR T-cell therapy do not mention this type of chorioretinitis. There are cases of uveitis, but specifically the retinal findings are not anything that have been reported in literature to be purely inflammatory. And I think they do, however, fit with a manifestation of an intraocular lymphoma.
Thank you very much.
Thank you.
Sandrine?
Thank you so much. I think we already have to conclude. The time is up, but I would like to sincerely thank all of our presenters. I think all of the cases were excellent, but also excellent presented, and I would like to share, to thank you for sharing your expertise. And I, of course, would like to thank you, all the participants and the audience, also for the lively interaction and for putting so many questions into the Q&A box. So for that, I would like to conclude and wish you a nice evening.
Thank you all.
Thank you. Bye-bye.
Bye. Thank you.
Thank you. Thank you. Bye-bye.